other side. I tell you, just from the standpoint of signing consent forms, we hand people consent forms all the time about you may need blood transfusion, you may die, whatever. It's very different when you're signing, especially like for your child. Yeah. If they're having their
That was who? Okay, what was the name of the movie? No.
I don't think,
Not The Guardian.
Let me, maybe, I don't know if I can find that or not.
And then, Dr. Clothier, while you do that, is it fair to say, is it fair to cast this aspersion, saying, how do we know these doctors that are on the American Cancer Association's board that make these recommendations are not owned by insurance companies?
Yeah, I do think that there is an ethical line drawn between the two.
May I say that, or?
Yeah, you can say they're not, because they're not, I believe.
I'm going to let you say they're not.
Sure.
I'm going to raise the question.
Okay, that sounds fair. Yeah, absolutely. Oh, I'm not getting anywhere right now with this.
Here we go.
Okay, we'll find it out later.
Well, I'll tell you what, folks. Welcome back to JP and Dr. B. We're doing a little picking here on the show today with some electric guitar. I'll tell you.
I'm digging this new music.
I'm digging this new music as well, getting your drive started. Thank you for sharing your first cup of coffee. We are talking with Dr. Norm Clothier, our resident expert medical doctor, and we are talking women's screenings, and it is quite controversial. Do you get the mammogram? Do you not get the mammogram? Doctors are, there's a new release from the American Cancer Association that you do it yearly between 45 and 54. Then you do an assessment. And again, that big question or that big conversation you have with your doctor, well, you're not going to live anyway, so why bother? And that's a no way good fun, not happening kind of conversation.
I agree. Yeah, you're just not going to have that discussion with the patient. We're all so pro-life and pro, we can help you get through this, that nobody's going to just draw the line and say, you don't need screening anymore because that's trouble.
Well, and I'm going to argue that, you can't take the God factor out of things.
Exactly. Absolutely.
I've heard people that were going to be gone. They're dead, their history, but their faith, the faith around them, their faith community helps raise into prayer, and God puts his healing hands on. Heck, that's what we read about in the Bible, is Christ going around and healing.
And healing, absolutely. And I've seen people with mammograms with a mass on the mammogram who then go to God in prayer and then have another mammogram like for the procedure and it's gone. So that evidence is there.
Yeah,
definitely.
Absolutely. And so, who are the people that are on the American Cancer Association where they get to make these decisions?
Right, that's a great question because it's there's a little bit of an air of mystery, behind that, but it is a group of experts, and the way that is defined is typically, and I don't mean this disrespectfully, but by their own group. In other words, people who have done years of cancer research, years of breast tumor research, years of mammogram research. So it generally is people who have been in the specialty dealing with that issue for a long, long time. And I don't mean to say they're all, fossils about to die. And, I'm not implying that. But I think they typically probably have 20 to 40 years of experience in dealing in the industry. And they tend to not be practicing much clinical medicine. They tend to sit around and review research all the time. So they are really specialists at analyzing information as much as anything.
And I'll tell you, when I'm dealing with lawyers in the courtroom, give me somebody who's gone to a law school that teaches the practice of law versus the theory of law.
Sure, and that's part of the debate within medicine itself, is that when we are handed guidelines, these are typically not people who see patients on a day-to-day basis. And it's somewhat easy to say, from a boardroom standpoint, just quit screening at age 55 if their life expectancy isn't very long, or 65. But it's very different to have that patient sitting in the office looking you eye to eye and try to tell someone, you're not in the group that we screen because we don't think you're going to live anyway.
Yeah, that's
there's nothing more averse to the type of practice I have than that, because we always are optimistic,
Right,
you know,
hope.
and always looking, for
We,
the
we
cure.
look to you guys for hope. I mean,
Right.
you can tell us the bad news, but then tell us, you know what, I'm going to do everything I can to make you better.
Absolutely.
You know,
So-
and here's the other question it begs, and I'm going to let you answer this question. You know, is the American Cancer Association, the FDA, all these people that have impacts on our health, I mean, are they owned by insurance companies? So they make these decisions and say, well, at 54, if their life expectancy is too short, we don't want to spend any more money, so just cut them off.
Sure. I think there's a lot of debate about that, a lot of discussion, but I can tell you, I do believe these are ethical people. And I think that there is not influence by private industry. Now, whether there's influence by government in terms of the FDA, for instance, I think we always have to realize who runs an organization. But a private group, like, for instance, the American Academy of Family Physicians, the American Medical Association, the American Cancer Society, American College of Surgeons, all these groups absolutely disclose any ethical dilemma that they have. So, in other words, if they have research that's funded by a pharmaceutical company or funded by the government, they disclose that. So you can always find out who has potential influence, and by disclosing that, essentially everyone agrees we'll take that with, what it's worth and weigh it in balance.
And
Right.
I think it's disgusting to ride someone off before they're even gone. Like
Well,
I heard
yeah.
somewhere,
Yeah.
Don't plan my funeral till I'm gone. If I'm still here, I'm still a living human being.
Oh,
I'm
absolutely.
not dead.
And I have not planned your funeral, Kelly. So I just wanted to point that
I was
out.
really worried.
That is so
yeah,
sweet.
I
That's so nice.
I know
Dr.
that's a
Clover.
delicate question to ask.
It
So,
is, really is.
Now I'll tell you, we are pro-life, and every maneuver, medically speaking, that we can do should be to prolong quality of life and prolong life in a meaningful, healthy way. And I agree with you. I think it is impossible to pick and choose, who's going to have a certain life expectancy. There's just too much human variation.
Well, and that goes back to playing God.
Absolutely.
I mean,
Yeah.
that's up to him. When it's
We're
time
not
to
in that
go,
role.
that's right. When it's time to go, it's time to go.
Yeah,
And
and
he'll let
you could
know.
be the world's healthiest looking person and have a bad car wreck. I mean,
Right.
there's nothing that determines that
Well,
one way or the other.
And we've heard those guys that are out jogging that are in perfect health,
Sure.
low body fat, eating exactly what they're supposed to be eating, and they drop dead of a heart attack in the middle of their jog.
Absolutely.
I mean,
and that gets to going back to screening, like mammography. That gets to the issue that even with screening, we can't predict everything. And that's part of the debate too, I think, about mammograms and other studies, is that not everything can be picked up in a perfect way. For instance, if we all did what most people I know in medicine would like to do, which is an annual mammogram starting at 40, so once a year, who's to say that cancer doesn't begin to develop a week after a mammogram and go for 51
Yeah.
weeks before you find it? It's just not perfect.
Right.
And you can't have a mammogram, every day or every week. So that gets into the other issues that are quite controversial, which is the so-called CBE and SBE. SBE is the self breast examination. If you're a woman who's been to a doctor, you've probably been told or asked, do you examine your own breasts for lumps and tumors and changes and such? And then the CBE is the clinical breast examination, which is while you're into your doctor having a breast exam to see if there are lumps or bumps or changes or tenderness. And the most recent guidelines actually say there's no use in doing a clinical breast exam or a self breast exam that leads to a false diagnosis or false concerns that then lead to further workup that frequently is not favorable for the patient, which
Right.
is very controversial
And
too.
I know in young women, caffeine lumps. What are they
Absolutely,
called? Those are common.
fibrocystic changes. Absolutely, it's sometimes referred to as fibrocystic disease. I tend to call it fibrocystic changes because it's not a disease. You don't catch it, but you absolutely can have changes in the cystic nature of the breast from caffeine and even from various other.
What are the alternatives, Dr. Clothier, to mammograms?
Yep, one is to consider an MRI. There are a lot of women who hate mammograms, as you referred to earlier, because of the perception that it's it's kind of a big, cold, ugly machine, and it presses on you and it hurts. And I would say that's highly dependent on the technician who's doing the exam. There is certainly a way to get someone through the exam without too much discomfort. I hear anecdotal stories of the person being rushed through and having a lot of pain. I don't think that's very common now. I think we really try to be very fair to women, very as pleasant as possible. But an MRI is an option. The problem is it's much higher cost. And it actually requires that you lay in a machine with your face down in the machine for about
Forever.
45 minutes. Yeah. It's a long test. It's very paranoia inducing, I would say.
Yeah, they say
And,
don't move, and when they say
yeah.
that, it makes you want to move.
Oh, absolutely.
Nothing
You know,
you
that's
can
the last
ignore.
thing. It's kind of like somebody saying don't yawn or don't scratch
Right.
or whatever. You know, all of a sudden you
Right.
don't
Yeah.
overcome.
Scratch.
Yeah, absolutely. And it's a very difficult thing. And Ventures is not yet shown to pick up anything more than a mammogram. So that's one option. Another is ultrasound. We sometimes order ultrasounds like on younger women who have changes that, like a pain or a lump, where a mammogram just isn't sensitive. That's the other issue is you don't start screening too early because breast tissue is just thicker and more dense in younger people, and so you can't see as much, in a younger person as older. And so an ultrasound is sometimes done. I would suggest the real thing to do is have a relationship with your doctor where you can discuss your concerns and where you can decide together whether you need a screening mammogram. A diagnostic mammogram is one where they can do extra views, and whether you need a biopsy, whether you need a referral to a breast specialist who can review all the options with you, whether you need an MRI or an ultrasound as opposed to a mammogram because of prior scar tissue or something like that. The real key is, again, having a long-term relationship with a doctor that you can discuss your concerns and that really your doctor can discuss their concerns with you. I personally am not very comfortable with the new recommendation to go once a year, 45 to 54. For one thing, people always forget the intervals and the gaps. I think it's much simpler to say once a year after 40, or even every other year. But again, a lot can happen that time. The challenge is evidence shows that if you screen every year, you're not necessarily picking up more disease. The problem, if you decide every other year, they determined every 3 years is a little too long, which makes sense. If you go every other year, you have a tendency to forget. So
Right.
it's a challenge.
Well, it is a challenge. Well, and Dr. Clothier, when Tanya went in and had hers done, her mammogram, it supposedly showed all of these terrible tumors. We went over to the Frisco Baylor Hospital, the new one they built, and met with a doctor that graduated from Stanford Medical School, top of her class, and we were freaked out.
Sure.
We took off from work, went in together, and only to come out and find out, no, you're fine. There's
Yeah,
nothing there.
it was normal findings.
Yeah, I mean,
You
so
know.
it's a little bit freakish. Well, fibrocysts.
Fibrocystic
Yeah.
changes can look like tumors, and you just have to weigh and balance whether that's the case. One thing, and I mean this favorably, radiologists are by their very nature very nervous, and they want to find every slight abnormality, which is what we want. We want them to pick up on things. The challenge is that a whole lot of things that look abnormal are actually normal over time. So you pick up more issues than actually exist. And that's
Absolutely.
part of the price you pay for screening.
Absolutely.
honestly.
Well, folks, this segment of Family Health is brought to you by Family Healthcare Associates. They have a doctor for all your family needs from prenatal to seniors. Family Healthcare Associates at FHCATX.com. That's FHCATX.com. Stay with us as we come back with JP and Dr. B and talk about all the victims of the tornado at Landmark West and what's going on now. You'll want to stay tuned.
Danielle's
Very
calling
good.
at 6:45.
Good job.
I need to go ahead and go. Maybe next week we could talk about pap smears a little bit. I wouldn't necessarily.
Well,
Let's just talk women's health.
Well, and I didn't jump into that because
Right.
you seemed to feel a little uncomfortable with it, so I
Yeah.
didn't want to.
I think discussing that's a little less family oriented and maybe a little more
Women on
But we
women
could do
oriented.
women's health, and I can mention as part of screening because we did. We talked about men. Whether we need digital rectal exam or labs, and I think women still need lab work and stuff like that.
Well,
So
I think that biologically speaking, I think we're fine. And
yeah,
honestly,
I just don't want to make too big a deal of
well,
it.
but I think a big question is
Yeah.
though, too, is let's say your 15-year-old becomes sexually active.
Yeah.
I mean, do we need to go get a? I mean, that is family medicine.
Yes,
I mean,
definitely, and that's
because
reality
moms don't,
medicine.
moms don't know what to do. And
That's
maybe,
right.
and maybe that's what we call it next week when we're in the middle of women's health again.
Yeah.
We talk reality medicine.
Yeah. I think that'd be
Yeah.
actually that'd be a great topic.
I mean, I think that we need to get into that
yeah, because
hardcore.
nobody wants to think about it.
Yeah.
And,
Right.
You know, but
You
it's
know.
it's reality.
And
yeah.
here's the truth of it. I mean, the truth of it is that you've got young men
Mm-hmm.
who are extremely testosterone driven.
Yeah.